Next slide. This is 62-year-old male patient. He is a relative of our hospital non-medical staff. Admitted with the severe loss of weight and loss of appetite, and in general appearance emaciated with the yellowish discoloration of the eyes. Then the patient was investigated. Next slide. And diagnosed as decompensated non-alcoholic liver cell disease complicated with the portal hypertension and recurrent spontaneous bacterial peritonitis. He was diagnosed at February 2021. At the same time, he was diagnosed as the gallstone disease and mild prostatomegaly. Next. And investigation-wise, platelets around 100 in full blood count and renal function test normal, upper GI normal, and liver biopsy not done. Next. And other liver function tests, DRI, all of the liver enzyme are DRI, and albumin globulin ratio also reversed, and 2D echo normal. Normal mean grade 1 MR and EF more than 60%. Peritoneal fluid analysis revealed SBBS, spontaneous bacterial peritonitis, and ultrasound abdomen. Chronic liver cell disease associated with a moderate splenomegaly with ascites, and gallstone in gallbladder, and mild prostatomegaly. Next. Past medical history, he known patient with hypertension. Earlier he was on amlodipine, but it was changed to losartan due to the ankle edema. Next. And the symptoms analysis. Earlier he was admitted with a severe loss of appetite and loss of weight with the nausea, and lethargic, emaciated, and generalized body ache, and abdominal distension or generalized abdominal pain plus or minus fever, and bilateral angle edema, poor sleep, generalized headache, and mild depressive symptoms. Those are managed with the nausea, managed with the antiemetic, and that abdominal distension and generalized abdominal pain and fever managed with the IV antibiotic cover up with the, and bilateral angle edema, Lasix with a spironolactone, and other SPV managed with the thiamine and other routine medicine. Next. And it's a family tree. This is a family tree. He was the father of the 3 children and a retired government servant and good family support. And he had 5 siblings, 3 male and 2 female. All are living healthy. Next. And he's a Hindu and married Hindu. And patient believes spiritual activities, but not without a meaningful basis. Next. And communication is a Tamil speaking family, and but does not like to speak much due to the depression, but depression reduced by the family support. He had a good family support. Next. And he cooperated with the medical team, and earlier I told he was mildly depressed but improved by the family support. Next. Finally, patient admitted unconscious and managed as the hepatic encephalopathy, intubated and ICU care given, but he passed away in 2 days. Next. And these are my questions. First one is how to manage appetite and nutritional requirement in end-stage liver disease patient, mainly the oral. How can manage the oral? Because patient and family members also worried about that patient didn't take any food orally like that. Then I want to discuss here how to manage the appetite orally and nutritional requirements. Second one is the usually all of our patient thinking liver failure due to the alcohol, but this patient in the lifetime not consume alcohol, but he is affected by the end-stage renal liver cell disease. Uh, then how can we inform him and his relation? Because this patient relation and patient also didn't understand. Uh, uh, repeatedly asked to us how I got the liver disease because I didn't take the alcohol like that. Then how to inform him and his family. Then next one, how to manage a patient who is a relative to hospital, who is a relative to the hospital staff, because this patient also one of the our hospital staff father. But I mentioned earlier also we intubate that patient and ICU care also given to that patient due to is the father of our hospital staff. Then how can manage like this condition?
Okay, that's great. Thanks for that case and questions to have some discussion about. Does anybody have any comments about the case or other questions about the case or any thoughts about these questions?
Anyone from the participants would you like to ask Dr. Sanjeevan any questions related to the case he has presented?
Okay, well, let's start with the first question that he asked, and then maybe we can go back and find some other things to dive into too. So how to manage appetite and nutritional requirements in end-stage liver disease patients. I'm sure many of you see many patients with liver disease of varying severity. And it sounds like your particular question, Sanjeevan, is somewhat related to like when people are more encephalopathic and they can't really swallow well, or they just have poor appetite and they can't tolerate oral intake. Is that part of your question?
Yeah, orally how can manage orally?
Yeah.
Because we can manage usually the parental IV and sorry IV, but how can manage orally this patient? Because patient and his relation worried about the oral intake. That's the
Right.
problem. But he had done poor appetite, those symptoms he had, but he couldn't take orally.
Yeah. And when he took things orally, did he vomit or did he?
Nauseated like that, but we treated with that.
Nauseated.
Yes.
Yeah. Okay. Okay. Does anybody have any thoughts about how they would manage that in this situation?
You can type your answer in the chat as well. We'll read it out for you if you're not comfortable speaking.
Maybe we can just go down the list and I can call on people to answer. Let's see, Dr. Thamayanthan. Sorry if I'm pronouncing your name wrong. Do you have any thoughts on that case or situation, how you would manage that if you were seeing that?
Oral way NG is better.
NG is better.
NG feeding.
Okay. Anybody disagree or agree with that? What are the problems with NG feeding in these types of patients? They sometimes it's done, but what can be some of the problems? Yeah, varices.
So, normal, but sometimes variceal bleeding.
For sure. Yeah, so it's good to know that people don't have varices. And the other thing, putting an NG tube in someone with end-stage liver disease is they're often encephalopathic and they're often on the edge of being delirious anyways. So putting in NG tubes can make people more agitated and more delirious. So sometimes it's necessary depending on what the goals are. I think the appetite and nutritional approach in these patients also really goes back to what the overall goals of care in the treatment of the patient is, which in palliative care, we always come back to what the goals of care are as a primary thing to guide all other treatments. So if he's in a situation where we don't really think his acute liver disease is reversible and the focus is more on helping him to have some quality of life, then our interventions might be quite different. It sounds like in his case, like he had kind of unclear cause of his liver disease. Is that right? Like he didn't get a biopsy done, and it wasn't really clear if there was an infection or some other metabolic cause that was contributing to it, or is that right, Sanjeevan?
I couldn't. Hello?
Is it seems like in his case that there wasn't really a clear cause of his liver disease. Like we didn't know why he has liver disease. Is that right? Oh, can you hear me now?
Yeah. So can someone like who understood the question, can you just try to translate the question to Dr. Sanjeevan if
Oh,
you
yeah.
don't mind?
Yes, cause was not
Hello?
known.
Anyone?
Biopsy not taken. That's why we don't know the cause of the liver disease.
Yeah. So I guess it's a little bit hard to know too if it's there's nothing really treatable, I guess, in that sense when you don't know the cause. So in terms of managing nausea and decreased appetite in end-stage liver disease, I think it's a few factors. One is the physical pressure of cirrhosis and ascites on the stomach, which contributes to nausea. So if people have really, really massive and tense ascites, then doing a paracentesis and draining off fluid can sometimes help with their oral intake if they can tolerate more intake. And usually, like with other times where it's difficult to be taking in a lot of food at one time, we suggest, smaller, softer amounts in smaller, more frequent portions. In terms of medications to help with nausea, we do sometimes use things like metoclopramide to help with pushing the food through the stomach as a prokinetic agent. It's the other thing with liver disease and nutrition is just being mindful of the protein intake, because you obviously need some protein, but excess amounts of protein can sometimes contribute to hepatic encephalopathy too. So it's just good to keep a balanced approach to that. An NG tube, as I say, is an option if the goals are really for aggressive care. And it sounds like in his case, like he was going to ICU and there was thought that his encephalopathy might be fixable. Is that right? I guess initially?
Yes.
Yeah. So sometimes NG tube is needed in that case. And how do you manage hepatic encephalopathy there? What kind of treatments do you have? Can you hear me, Sanjeevan? Or what? How do you manage hepatic encephalopathy there?
Yeah. Finally, manage with the hepatic encephalopathy.
What type of treatments do you use for hepatic encephalopathy where you are?
Yeah, manage time and lactic loss, antibiotic or
Okay.
metronidazole, antibiotics.
Yeah, well, that's good. Yeah, sometimes for the
Lactic-
lactulose, if people really
lactic-
can't take things in orally, then we are needing to do an NG tube to put lactulose down, which actually helps relieve their encephalopathy overall. And then and Shobika's just putting something in the chat. Should also avoid constipation, which might further cause nausea as well as exacerbate hepatic encephalopathy. That's very, very important point. Yeah. So for patients with encephalopathy or cirrhosis that do have severe pain, and sometimes their pain requires the use of opioids to manage things like that, you really have to be very attentive to treat and prevent constipation because constipation can exacerbate encephalopathy. Okay. Next question was, if the patient does not consume alcohol, but he's affected by liver disease, how do we talk to him and his family about this? How would people approach that conversation, or how did you approach that conversation, Sanjeevan?
Yeah. But they are not satisfied about that because his father, their father, not taking alcohol in the lifetime. But
Mm-hmm.
always, even now also, they ask how to he got the liver disease like that.
Mm-hmm. What did you say to them, or how did you explain it? What explanation did you give to them?
That daughters educated ones know, then we tell with evidence our side evidence, but our VP also decision also told no, then they understood.
Okay. Has anybody else encountered that in trying to explain non-alcoholic liver disease to patients and family members? How those conversations have gone?
Yeah, the liver disease may due to some idiopathic, or we have to find the cause. I think there's no time for the find out the cause. That's maybe the reason they will put that a non-alcoholic liver disease without any cause. If you are investigated further, so definitely we will go some extent. There are any more causes, then only we can label as non-alcoholic and the idiopathic possibility. But I think the short period of admission and the patient end up with the encephalopathy, maybe this may be the reason they will put as this situation. Anyhow, we can explain the family members. There's a possibility of an idiopathic also possible due to this chronic liver cell disease. There's one option also there. So, but usually there's alcohol related, but there are some cases like this. So we can explain leisurely these things to family members. Thank you.
Yeah, I think that's a great point. And it sounds like the is it right, Sanjeevan? So he was admitted and went to IC, like admitted and diagnosed with liver disease and went to ICU, like all on the same admission, or?
Yes, February to August. He admitted in the February.
Oh, okay, so there was
Yeah.
some time.
Yeah.
And
But
so
we
we're
didn't
thinking,
take the biopsy also because patient recurrent admission with the spontaneous ascites with the spontaneous bacterial peritonitis and like that. Then
Oh,
we
okay.
didn't go for the biopsy also, liver biopsy.
Okay. Yeah, I think it's, as was said, there are many different causes of cirrhosis, and sounds like you worked up the possibilities that you could within the confines of not being able to do a biopsy. and even with all those investigations, and even in patients where all the investigations are able to be done, there's a certain percentage that do remain idiopathic, and we don't know the cause, but the
Yes.
treatments are still fairly similar in that case, and it's really trying to manage exacerbations. And I think ultimately explaining to people that it is a life-limiting illness that will progress over time, and that the liver is a very vital organ. So in the absence of transplantation or other treatments, it will progress. It sounds like he presented at fairly late stage, so that's obviously more shocking for the family to have to kind of get used to that. But yeah, I think you can also kind of reassure them that it's not something that there's not indication that it's something he did, or sometimes there's guilt associated with alcohol related liver disease, or shame in the family or something like that, and that these things do kind of come on like other health related issues that are difficult to explain the cause of sometimes. So your last question was how to manage a patient who is a relative to hospital staff. Were there particular problems with their challenges with this that you felt, or Sanjeevan, were there particular, like, was the hospital staff kind of asking for extra treatments you normally wouldn't do, or were they asking for information that you normally wouldn't give, or?
Yes, we explain about the patient condition, but he want to treat. He want to condition, but he don't like to put the. He want to intubate like that.
Yeah.
Intubate and give the full management. He want to give the full management. Then we manage intubate and give the ICU care. But finally, he passed it. Yeah.
Yeah, that is challenging, particularly when they are hospital staff. Does anybody else have any other response to that for patients and families that are requesting treatments that you think are not appropriate or maybe not beneficial? How do you manage those situations?
Yeah, the request.
How about
Are we done,
Vern?
sir?
Oh,
Yes, sorry. Please go ahead.
how about Vernie Bala? Do you have any thoughts on that? Do you have patients ever that request treatments that you don't think is indicated or useful? How do you manage that? I don't know if Fernie is there. Okay.
Dharmipala? Madam, are you there? Hello? Ma'am, maybe you have to unmute and speak. Your microphone is muted.
Okay. How about Paul Raj? Do you have any thoughts? Oh,
Yeah,
we can't
need
quite. Oh, there we. Perfect. Here we go.
Yeah, for this family need a family support and good counseling, as well as that make him to realize the reality and relieve little bit pain if
Mhm,
they are.
mhm. In Sri Lanka, like if families insist on going to the ICU and having intubation and those types of things, and situations where you don't think it's appropriate, are physicians able to say, no, we will not do this, or are they kind of obligated to do it? How does that usually work?
In Sri Lanka, that uh, that we are not focusing so much of pain relieving, but
Yeah.
we are much worrying about that patient will get addicted, like morphine, petadine, penahan. So in my case, I feel that the patient is going to the palliative care patient. Anyhow, that patient going to be died. So for that,
Yeah.
why we have to worry about that addicting the patient, so that we can give. When we compare that using that painkiller with the developed countries, but Sri Lanka is low level, like 4%, like we are using. So for
I
that,
guess not necessarily in terms of the pain medicine itself. That's a part of things, but more in terms of like a case like this where a family is asking
sorry,
to go to a case like this where the family is asking to go to the ICU, and it sounds like the hospital medical staff feel like that's not a good idea, that it's probably not going to be a helpful thing. Do the medical staff, do the doctors, are they able to say, no, we will not take you to the ICU, or is it usually an expectation that you would do what the family wants?
No, we can like
taking the ICU and doing some treatment is much better sometimes. Anyhow, that relatives feelings and sometimes that in time, just life in time. So they may think that they can look after the patients, keeping at home. So we have to respect that relative feelings, that who is a caregivers especially, and son or daughter, like according to their opinion, and also that expert opinion, like VP or doctor's opinion, we can do the things, I feel.
Thank you. Was somebody else going to say something there too? Sanjeevan or?
There are like a couple of answers in the chat.
Yes. Okay. So from Shobika, we can explain the suffering the patient will face unnecessarily, and it depends from place to place. In case of hospital staff, it's sometimes really difficult. Even they know the situation, they always want to give a try. Yeah, absolutely. So it depends. It depends a lot on the underlying diagnosis too. So in patients that have, say very end stage malignancies, where there is really clearly no further treatment options and the disease is progressing and ICU care is not going to help reverse any of those issues, it's a little bit easier to kind of say medically that this is not going to be a helpful intervention. For somebody with liver disease that's kind of an unclear cause, and a somewhat a recent diagnosis, even though they're very sick, it is a little bit harder to say sometimes whether there might be some ability to improve the encephalopathy and they can get some improvement, at least for a period of time. So it's a little bit related to how certain you are that the intervention will not be helpful. One question that we often ask patients is when they're trying to think about, the types of treatments that they want is, what are you willing to go through for the possibility of living longer, or the possibility of more time? And some patients are really, willing to go through a lot of pain and suffering for any possibility of living any longer, even if they are experiencing a lot of pain. But many other patients are absolutely not wanting to experience pain and suffering if it's very unlikely to benefit them. And so helping get a sense of what their underlying values are is important, and families can help us understand that too. So, but in Canada, at least, I can speak for here, and it is a little bit different in different parts of the world. If physicians and the treating medical team feel like a medical intervention is not indicated or will not be helpful, we're not obligated to offer it to patients. So one example is, patients that we really don't think would benefit from CPR if they had a cardiac arrest or something like that, if they have very end stage disease from other causes. We can kind of make a medical decision to not perform CPR ahead of time if we feel that's appropriate, but that's usually done with, a few different physicians kind of giving that opinion, even if it's in disagreement with the family. So it is, but it's a bit particular to different countries and practices. So I obviously do what makes sense within your own practice. So anybody else have any comments about that case? We maybe should move on to the next one, but thanks very much, Dr. Sanjeevan.
Okay, thank you.
Okay.
Sir, we are supposed to start a second presentation. So who is Dr. Kandeepan, who is going to present his case, but he's not here. I tried calling him, I tried texting him, but there's no response.
Okay, well, that's going to be challenging then.
Yeah, because he sent his presentation this evening, very late.
Yeah.
So I thought like when he sent that, like he's gonna join, but like I'm trying to call him since 8 o'clock, but there's no response. If you have, any one of you have his local number, would you mind trying once whether he's going to join or not? Because it's already 8:40. Is that a jug or a cup, sir? Which you're holding?
This is a cup, big cup.
Big cup, okay.
Big cup
Okay.
that's probably amplified by the angle of my camera, but yes, my coffee to start the morning here. It's 7 o'clock in the morning here, so.
Just kidding. So can anyone like just try? Because I tried calling him and text him like 3-4 times. There's no response. So even for this question, everyone is so quiet. I don't know what to do.
Does anybody else have any other questions about that case in the meantime, or?
So usually like from our side, like whichever patient it is, this is related to the first question which Dr. Sanjeevan has pointed out, managing appetite and like nutritional requirement in end of life care and stage liver disease patients. So, hello, can you hear me, sir?
Yeah, that's good.
Yeah. So usually like what we have learned and what we normally do is, I mean, we try to tell the patient's family, I mean, telling them that the requirement of the food automatically comes down for a patient suffering from end stage or chronic diseases who are in end of life care. So they cannot eat as we do. So this is what we try to do, and some few family members insist on giving them IV fluids. They think that that is going to help them instead of having a normal diet and as an oral intake. So even then, like, we try to tell them that, like, this is nothing, this is not going to help in a big way. Or like there are like some situations where the patients want to take food, but they are unable to take. I mean, the rice tube part of it, if the patient is really hungry and feels hunger and want to have food, then usually like we go for a rice tube insertion. So maybe not suggested during end of life care when they are like fit and they want to eat. And one more suggestion, what we try to give during end of life care is, if the patients want to eat, but still they cannot swallow, and even if they have Ryle's tube, so we tell them to give small little frequent meals every hour or every 2 hours. And then whatever food they have or they like, or homemade food, whichever they want to eat. So we ask them to put it in the mouth, just feel the taste of it, chew for a while. Even if they cannot swallow, that's okay. They can spit it out just to get the feel of taste and other things. So these are like 3-4 points which we try to tell our patients in our hospital, home care, or a hospice settings. I just wanted to just tell you.
Yeah, well, that's great points. I'll just mention too, I mean, IV fluids, we talked a little bit about that in other sessions. So in certain cases, it can be helpful for dehydration, or if there's medications building up and causing side effects or something. But in liver disease patients, they really can cause a lot of side effects with the edema and ascites very quickly. So obviously you have to be pretty balanced with IV fluids use in these patients, because they can get a lot of ascites very quickly. The other thing with liver disease patients they often get is itching, or pruritus. Anybody encountered that, or how do you manage pruritus in a patient with liver disease? How about Soundararaja? Oh,
What the number? Kokula Raja, sir.
oh,
Hello.
Yeah.
Please
oh,
speak.
hi.
Yeah.
Do you,
I,
how,
sorry, I try to can't even, but I difficult to catch him. I try to local number.
okay, thank you very much for your trying.
Several
That's
times I
great.
try to him and ringing, but not to take him.
Okay, well, hopefully everything is okay. And maybe we'll have to get his presentation some other time. Do you have any experience with end-stage liver disease patients or other challenges that you face with them? We were just mentioning about itchiness or other symptoms that you find difficult to manage with them.
Oh, I haven't any experience about that because I'm working in the periphery hospital. Most of the time we are giving the emergency management only.
Okay. Anybody else have any experience with challenges dealing with liver disease patients? So I'll just say for itchiness, for pruritus, there's a few different medicines. I mean, first of all, we try to help treat the encephalopathy and optimize the liver function as much as possible. There are other medicines like cholestyramine that sometimes can help bind some of the bile acids in the gut, and then other medicines like the opioid antagonists. I don't know if you have access to those there, but things like naltrexone, if patients are not on opioids, can actually be quite helpful for itchiness. Many of our patients in palliative care have quite significant pain or other needs to be on opioids, so those are not good options in those patients. And then sometimes in more long-term situations, antidepressants like SSRIs, like sertraline and things like that, can be helpful for itchiness as well. But usually things like antihistamines are not that helpful for itchiness in liver disease and renal and kidney disease. So it often sedates patients, and maybe they're not as aware of their itchiness when they're on antihistamines, but it's usually not as helpful. Yeah.
So usually they say that opioids, morphine is not recommended in liver disease patients or liver failure. Is that true?
I mean, I'd probably be use more gentle doses in those patients. I wouldn't say it's contraindicated. Usually we worry more about morphine in kidney disease than in liver disease, but yeah, more gentle doses to start with. And like we talked about earlier, preventing constipation in these patients is very, very, I mean, it's always important in every patient, but it's very, very important in these patients because it can precipitate encephalopathy, which is more of a complication. So.
Thank you.
Yeah.
So, sir, I think we may have to wind up today, because if there are no
Yeah.
questions from any of the participants, because it's already 8:50, and I don't think Dr. Kantipan is going to join us now. So because
Okay.
he's not responding. So open to any other questions or any clarifications from the participants.
I was just going to ask too, so it sounds like there's quite a bit of organization with Dr. Katie's and others to try to help get some clinical programs going with palliative care in the different districts, hopefully even in the next weeks. I didn't know who of you may be involved with that and how you felt like that was getting organized, if you had particular concerns or questions about that.
Yes, in Vavuniya district, one of the district from northern province, yesterday we have the meeting with the regional director of health service, with the doctors, those who are involving this program and already trained this palliative care. So altogether 5 doctors at the moment in the Vavuniya district and 2 nursing officers. So we have collaborated with the initiator, Dr. Madhuravan was started this program in Vavuniya district. So we have a good meeting with the RDHS, and we want to meet the oncologist at the district general hospital Vavuniya and the physicians for this next level meeting, and we want to collect data of palliative care patients from them. Most probably mid of this month we will start the field visit program. So now we are gathering the data collection from the hospital and the end-stage disease patient details also. So we plan the next week also another program meeting with the physician and the oncologist. So most probably Vavuniya district will restart the program in the mid of December. That's the way we have initiated now.
Okay, that's great. That's fantastic. Yeah. Anybody else have any other comments about that, or? So we are kind of planning a little bit about how we will continue to connect with each other as we move towards the end of this course. So I think we have another session next week would kind of be our last case presentation session of this particular course, but it's going to be very important, I think, that we keep doing these case presentations moving forward so that we can talk about challenges that you're encountering as you see more patients in your districts. So we probably will try to continue with a almost weekly case discussion time going forward. And then we were thinking maybe having each district do one, present some cases on a rotating basis. So we could have one district per week kind of rotating around in the schedule, and then have some time for discussion. And then there's the WhatsApp group that can be quite a helpful resource to get more immediate feedback and support from others. So with Urhan and myself and Dr. Vera and others can be on that and try to give you more real-time assistance. So those can be helpful moving forward. In terms of the end of the course itself, so we'll finish up with the case presentations. In terms of finalizing things and completing all the requirements to get a certificate and things from this course, we'll be sending out a kind of take-home quiz or exam that you can work on in your own time, just as kind of a summary of the sessions that we've had and some basic questions that you can work on. And it's more based on completion. So we just encourage you to work on it to the best of your ability, and you can open book or look things up and things like that. And then when you send that back, and if you've presented a case presentation and been attending a sufficient number of sessions as we previously outlined, then we'll be able to issue a certificate from the Hyderabad Center for you to at least have some record of your commitment and time that you've put into this course over the last several months. So thanks everybody for joining this morning, and sorry we got cut a little bit short. Maybe Vanilla, for next week, shall we try to maybe have a little bit like an hour and a half session and do 3 cases next week to
If that is all right with I mean, I'll try to check with Dr. Kandeepan sir. So if he says like we'll try to do it for next week, we'll do 3 case presentations. If not, I think next week Dr. Prashant and Dr. Vijay Gunanathan are going to present the cases. So as per this schedule. So as Dr. Kandeepan was not available today, so we'll see if we can do it. And sir, can we start a little early if it is all right with everyone? Because we have 3 cases and it will go on if the discussion extends. I mean, can we do maybe like little early? Is that all right? I don't know. I'm just asking our participants. Will it be too early for you, sir, next week? If you start a little early, no?
I'd probably rather go a half an hour later, but it depends on what works best. If it's best for people to go earlier, then we can do that too. But
okay, maybe we'll just stick, because it's 1 week. Let's not, maybe we'll not confuse. So we'll stick to 8 p.m. I think that should be fine.
And then we could have another session, I guess, the next week too, if we wanted to. I don't know if there's anybody else that wanted to present any other cases. And 3 cases is kind of a lot for one session too.
So
but
I felt the same.
so we could have one other session on maybe that's better, just to do another session on the 15th, and then we can have a little bit more time for discussion too. Does that sound okay?
Yeah, maybe I'll just speak to Dr. Kandeepan whenever get time, and we'll get back, sir.
Yeah, that's
Thank
great.
you so much. So shall we just wind up for today, sir?
That sounds good. Thanks, everybody.
Thank you.
Thank you so much. I think please, I have shared the feedback link. Please do not forget, and we'll be meeting you on 8th December. Yeah, 8th December at 8 p.m. same time. And we'll see how many cases we can present. I think we already have Dr. Prashant and Dr. Vijay who will be presenting. And I'll check with Dr. Kandeepan and get back, and I'll post it in the group. Thank you so much, but please do not forget to share your feedback. Thank you. Thanks, everyone. Thank you, Jonathan, sir. Bye.
Okay, thanks.
Good morning and good night to everyone.
Good morning and good night.